Hello, everybody. So we're gonna get started. Welcome to the Global Frailty Network Frailty Seminar Series. My name is Jorge G. Ruiz. I'm Medical Director at Memorial Healthcare System in Hollywood, Florida. I'm faculty at Florida Atlantic University, Smith College of Medicine. Our speaker for today is Dr. Ariela Orkaby from Harvard University and New England VA. I will introduce her in a minute. Just before I forget, I wanted to make sure that when you ask your questions, you use the WebEx chat button. At the end of the talk, of course, we will have time for questions, and you can start, putting your questions in the chat as soon as you can. So now let me do the introductions for our distinguished speaker, and today we have the privilege of having Dr. Ariela Orkaby, who is an assistant professor of medicine at Harvard Medical School. She completed her training in internal medicine at Boston Medical Center, geriatrics and preventive cardiology in the Harvard Combined Program, and epidemiology at the Harvard School of Public Health. Dr. Orkaby is funded by NIH and the VA to study the role of frailty in cardiovascular disease prevention, with particular attention to the role of evidence-based medications in older adults who have often been excluded from clinical trials. Her work has been published in leading medical journals, including the New England Journal of Medicine and the Journal of the American Medical Association. She currently serves as Director of Frailty Research in the Division of Aging at Brigham and Women's Hospital, and is Associate Director for Research Training in the New England Geriatric Research Education and Clinical Center, GREC, at the Boston Veterans Hospital. At the Boston VA, she also directs the Frailty Working Group, and she has led the initiatives to develop the VA-Frailty Index for the VA national and clinical data sets using the National Electronic Health Record. Most recently, she's facilitating a national work group to incorporate the VA-Frailty Index into the National Electronic Health Record system across the VA, the largest healthcare system in the United States, to make it readily accessible for clinical use. And she's going to share some of that experience with us today. So now, without further ado, I'll let Dr. Orkaby talk about an update on the VA-Frailty Index moving from big data to the clinic. Ariela?
Thank you so much, Dr. Ruiz, and thank you for the generous introduction. I'm really excited to be back with all of you to talk about the VA-Frailty Index and what we've been doing over the last 2 years since I last had an opportunity to present to this group. So just very briefly, I have no conflicts of interest. I do have grant funding to disclose from the NIH, specifically from the NIA and from the U.S. Department of Veteran Affairs. So the objectives for today are going to be to review the VA-Frailty Index, what goes into it, how did we develop it, understand some of the epidemiology, how we're using it for research around the nation and elsewhere. We'll get into some comparisons to other frailty tools, both other automated tools or electronic health record or claims-based tools, and direct assessments. And then finally, what are we doing to bring the VA-FI to the clinics around the country? So I don't think I need to tell this group that the population is aging. I think we all know that. Where I'd like to start is thinking about life expectancy estimates. And if we were just to look at an actuarial table, we all know that an average 80-year-old, this is for women, has about 9 or 10 years of additional life expectancy. But these actuarial tables only tell a part of the story. There are interquartile ranges. There is a lot of individual differences between older adults, between every human being, frankly. And so you may see an 80-year-old in your clinic who looks as robust as the 45-year-old who you just saw right before, or you might see somebody in a nursing home who is 80 with an end-stage diagnosis, that may be end-stage dementia, who is actually very frail at the very end of life. And so I like to think of this as the age-frailty mismatch. Other people think about this as the biologic chronologic age mismatch. And this is where we are today, trying to move away from just looking at that one number that may show up in a patient's chart or that we're used to as we're presenting on rounds with our patients, to move away from saying, well, this is an 80-year-old female with X chronic conditions, and rather think about who is this older adult, older person in front of us, what is their frailty, and how might that help direct their care. And so the comprehensive geriatric assessment, which really forms the basis of what we do for clinical frailty assessments, is an incredibly comprehensive tool, and it is too comprehensive for most clinics outside of most geriatricians' offices. And I might even say in some geriatric clinics, the CGA is sometimes too broad for what we need. There are core components of the CGA, and obviously there are many different elements that go into that. Derived from the CGA is what we know and love as the Rockwood cumulative deficit model of frailty. And it really takes from the CGA many of these core elements to put together what I like to think of as really a network of how is the health system doing. And so this is the model that we have based our VA-Frailty Index on. And I'll come back to exactly all of the details here, but just want to make sure that we're all on the same page. There are lots of frailty definitions out there. What we're talking about today is really going to be based on the cumulative deficit model of frailty. And so the VA, or the Veterans Health Administration, is the largest integrated healthcare network in the United States. Since it was established as a federal agency in the 1930s, over 26 million veterans have been cared for in VA hospitals across the United States. And so this map is actually a couple years old. There are now over 170 medical centers with over 1,000 outpatient clinics served by over 350,000 staff members, giving care to about 10 million active veterans or patients throughout our system. And one of the things that makes the VA network unique is that it has been using a single EHR, electronic health record, since the 1980s, which is really remarkable, and I think one of the only systems in the country. What that means is you can be getting care in Hawaii and be transferred over to Boston for an advanced procedure and will have seamless access to medical records. And that is just incredible. Before Epic or Cerner or any other systems around, the VA has been doing this. And so what that means is that there is just a tremendous amount of data that's been collected over the decades. And so the VA EHR data are available in what is called the Corporate Data Warehouse, or CDW, which receives data inputs from all the VAs across the nation, including clinical data, research data, registry information, information from labs, from pharmaceuticals, medication administration, etc. All of this data sits together in the Corporate Data Warehouse and is cleaned. And this can all be linked to the Centers for Medicare and Medicaid billing data, which can capture claims that occur from medical encounters outside of the VA. Now, people over the age of 65, and in the United States, most individuals over 65 have access to Medicare. And so what this means is we've got a near complete picture of healthcare utilization for veterans age 65 and older across the entire VA. And so this, if we think about this, really amounts to some of the richest clinical data in the world. So when we were thinking about building a VA Frailty Index, we said, wow, we've got access to so much information. How are we going to start? So a few of us, myself and a few other geriatricians, came together in a room, and we said, this was back in about 2016, shortly after Dr. Andy Clegg from the UK had published his work on the Frailty Index for the UK NHS outpatient primary care system. And we said, we can do something similar for the VA. We went back to the Searle paper. At the time, that was really the guidebook that most people doing frailty research were turning to say, what are the criteria that we should be using as we think about all of this data to select the deficits that we're going to include in our VA Frailty Index. And so we really established it based on the comprehensive geriatric assessment, and using these criteria that deficits had to be related to health status, had to increase in prevalence with age, could not be fully saturated before the age of 65. They had to cover a range of health systems. It couldn't be everything related to morbidity or codes only associated with function or only lab values. And importantly, for the work that we were hoping to do in VA is have variables that could be assessed in the same way every time we wanted to go back in and measure frailty. And so this led us to identifying 5 distinct domains within our VA Frailty Index. That includes function, morbidity, cognition and mood, sensory impairment, and then another group of other or geriatric syndromes. And so what this really turned into was a 31-item VA Frailty Index that uses VA claims where we also augmented with CMS data. For our function components, we included codes related to arthritis and gout, falls, fatigue, use of durable medical equipment, which is unique, especially at the time, for claims-based frailty indices, codes for muscle wasting and cachexia, gait abnormality, Parkinson's disease, and peripheral vascular disease, all as markers for how somebody is functioning physically in their environment. We had a list of the usual morbidities that are often seen in a frailty index: anemia, atrial fibrillation, cancer, chronic kidney disease, coronary artery disease, diabetes, heart failure, hypertension, liver disease, lung disease, osteoporosis, stroke, and thyroid disorders. Some might say osteoporosis could really fall under our geriatrics and other category. I wouldn't disagree. This is just how we had classified it at the time. Sensory claims that we were able to capture were vision loss, hearing loss, and peripheral neuropathy. For memory and mood, we captured codes related to dementias, depression, and anxiety. And then finally, claims related to weight loss, chronic pain, failure to thrive, and incontinence. And within that, debility codes as well. And so this all boiled down to 31 items, but really, if you were to take a step back, this represents thousands of individual ICD-9 codes, which is what we were working with originally, and procedure codes and other utilization codes. So the first step that we did was to understand, well, how frail are US veterans? So we first looked at 2002. For those who know VA data, right around 2000, 2001, that's where our data becomes most reliable for modern research that we're doing for large data. And so we started in 2002 here, and we actually did a look back period of about 3 years. And the reason we did 3-year look back to capture claims is because in order to maintain primary care within VA, a veteran has to come in every 3 years. So we didn't want to miss healthy users who are only coming in to maintain their benefits, or they're not sick, they're not getting hospitalized, they're not coming to see specialists. So we didn't want to lose the non-frail or the healthy, well, older adults. So we looked back, and our initial for VA-FI code and how the way we set it up was a 3-year look back period. So in 2002, we identified 1.6 million veterans who were over age 65. 98% are male, which does represent the US veteran population. The mean age is 75, and only about 30% were frail. And that's really looking at the mildly frail in the green, the moderately frail in the yellow, and then in the red, the severely frail. When we looked at 2012, we saw that the prevalence of frailty had increased by 50%. So our cohort had increased from 1.6 million to 1.9 million veterans over the age of 65, still about 98% male. They're older as our population is aging, but the prevalence of frailty really had grown. And the greatest reduction was in the non-frail group. So there were similar, about 30% or so who were in that pre-frail zone, but it was a non-frail group that was reduced the most. In 2015, the United States transitioned to ICD-10 for claims data, and so that required us to update the VA-Frailty Index. And one of the first questions we asked as we were pulling in many more claims data, and I'll show some data about some of the data challenges we ran into. So we went from several thousand codes to, from about 714, actually to be precise, codes that were included in the initial VA-Frailty Index to almost 6,000 codes with the ICD-10 update. And what we found, though, even with that increase in codes, and even with our population growing in size from 1.9 million to almost 2.4 million in 2018, and with more women now, but 3% women, we found that the prevalence of frailty had actually remained quite stable, which was nice to see. We were still seeing that decline on the non-frail, but very stable in the pre-frail group. And we looked across the country. We looked at this over multiple years. I'm selecting 2018, which is a really just to avoid getting into some of the COVID era, and because this is post that ICD-10 change. And I just want to walk you through some of the data and give you a snapshot of what things looked like in 2018. So looking at this, about almost 11% of veterans were severely frail during this time, and actually most were living in the Southeast, Florida. Dr. Ruiz is really showing up high here, and there was also quite a number of individuals in the Northeast as well. So who are these veterans? Their mean age is about 75. Most are men. A nice distribution of race, which really reflects the VA population, about 79% white, almost 12% Black. There is an unknown or null group. There are veterans who choose not to share their race. And this is data is pulled from very well validated algorithms that are used across the nation. We also have a diverse representation of ethnicity. And so looking at these demographics, we wonder, does frailty group composition vary by race? The short answer is not really. The only group that stood out are Asian veterans. This is less than 1% of all veterans. They tended to be less likely to be frail and much more likely to be non-frail compared to all other racial groups. This is looking at sex. Now, granted, there are not that many women in this group, but we're still talking about 60 or 70,000 women, which is a very large number of women. There is no difference in frailty prevalence by sex, which was interesting for us to see. So thinking about the VAFI and its predictive ability to identify those at increased risk of mortality. So this is from our earlier work. One of our first questions actually was, what should the cutoff of the VAFI be? How do we define frailty? I showed you on the very early slide the cutoff of about 0.2, some say 0.25. There have been some publications that have said maybe 0.3 or 0.35 should be where we start to define frailty. But when we were first looking at this data and saying, what should our cutoff be for the VAFI to identify those who we are going to classify as frail, we ran an unrestricted cubic spline against the risk of mortality. And this is 2012, a cohort in 2012, followed through 2014. And we found that there was an inflection point right here, right at about 0.2 or 0.21. And that's where there was an exponential rise in the risk of frailty. I'm sorry, in the risk of mortality. And so we've gone with 0.2 as our cutoff to identify frailty, and it's really validated in this data. Because our data sets are so large, we went with these categories of mildly frail, moderately frail, and severely frail. And that's allowed us to do some really interesting work. So if we want to understand life expectancy estimates, going back to some of that actuarial tables that I mentioned at the beginning, one of the things that any clinician here knows very well, and I think most people intuitively understand, is that age is in many ways really just a number. It's not going to tell the whole story. And what we found in this data, focusing in first here on the men, is if we identified a male veteran who was 65 years old but was very frail, severely frail, the median additional survival time was less than 5 years. On the other hand, if we identified an 85-year-old veteran who was non-frail, the estimated median survival for that individual was over 6 years. And similar for women, women do have a longer life expectancy than men, which is shown here as well. And what this data really ignited was a question of, are we perhaps withholding preventive care and screening from older individuals who deserve it, and perhaps overscreening or offering preventive care to those who may not benefit? One of the big questions is cancer screening, for example. Right now, guidelines would suggest that anybody between the ages of 60 and 70 should have a screening colonoscopy. And yet, if you have an individual who's very frail or has any end-stage condition, it may not make sense to offer that person a screening colonoscopy because their likelihood of benefiting from that, from being alive for 10 years, is very low. On the other hand, many guidelines will say after the age of 75, maybe don't do any more screening. Some guidelines go down to the age of 70, others go up to the age of 80. Either way, there is this discrimination that's really based on age alone. That's really ageism. And some of the conversation that has been ongoing has been, how can we use frailty or a tool like the VAFI to reset life expectancy estimates and perhaps reconsider and allow an opportunity for shared decision-making between patients and their clinicians to say, hey, you're doing well, you're 75, you're 80 years old, but you're doing really well. There's nothing that we can see right now based on your medical history, based on your frailty scores, that suggests that you have a limited life expectancy. Perhaps we should consider doing some screening. Now, I don't want anybody to take from this that every 85-year-old deserves a colonoscopy and 65-year-olds should not have a colonoscopy, but rather to start thinking about, are we making decisions that are appropriate based on the physiologic or the biologic age of the individual that's in front of us. Now, to get into some of the data challenges, and this is actually some of the questions that I've gotten over time, especially as people try to take the VA-FI and apply it to their data sets, both within the VA and without a VA. One of the biggest questions that I get is, how many years of look back do we really need to calculate a frailty index? And so we looked at this within the VA, and we say, do we need to use a 1-year look back or a 3-year look back? And so this is showing here in the blue is the 1-year look back, and if we add in data from the last 3 years in the pink, it doesn't really make much of a difference. You might reclassify a small portion of individuals to a higher level of frailty, actually. But most importantly for us, as I said earlier, we don't want to miss the healthy users who are not coming into the VA because they don't need to. They're well. So we want to make sure we can include them. Another question is, what happens if we don't include data from outside the VA? Not everybody has access to the Medicare and Medicaid data. It actually isn't even feasible to do that when we're thinking about bringing a tool like this to the clinic. The Medicare data has to be cleaned. It has to go through multiple processes. It'll take usually on average about a 2 or 3 year lag between when a claim is filed until it can finally be used for research purposes. So for example, now in 2024, I've got all the 2021 data, but I can't yet access 2022. That'll be sometime later this year. And so we wanted to understand what happens if we only use the CDW data, just that data that's captured in the electronic health record in the VA. And here we do see a little bit more of a difference. We ended up with a reclassification about 1 in 4 veterans to a higher frailty category when we were able to bring in that Medicare data. Importantly, though, all the associations with mortality were maintained. So it didn't change the predictive ability of the VA-FI, but on an individual basis, from a veteran to veteran, it did make a difference with who was classified as frail or not frail. Most of that reclassification, though, really happens in that mild frailty category. It's not happening as much at the very severe. The other thing to consider is for studies that are really focusing on primary care or downstream quality improvement initiatives where we're hoping to integrate the VA-Frailty Index right at point of care, our early data is at least suggesting that for people who are coming in and getting their regular care in the VA, who aren't going outside for other for specialty care or even for primary care, CDW is doing a really good job. This is more at the population level as we're trying to understand who are the veterans that VA is caring for. Are we missing data? Short answer is yes, and yet the VA-Frailty Index is still working on the global level. Another important data challenge that came up was the impact of the ICD-9 conversion to ICD-10 on the prevalence of individual deficits. And so one question was, are we going to see big spikes in certain deficits? So overall, I will say across 31 deficits, there were about 5 or 6 that had some notable changes, all of which stabilized over time. The biggest change was for atrial fibrillation, and that really has to do with, and this is down here in the gray dotted line over here, this has to do with the number of procedure codes that could now be used. So AFib, or atrial fibrillation, is still a single code, but it has a lot more procedures that are now associated with it. Another change was with cancer. So this is in the orange dotted line, and there definitely was a change between 2015 and 2016. Some of this has to do with specificity of codes. So there are suddenly thousands of codes that could be used just for, cancer of this lobe of the liver or of the femur, as opposed to, just the lower leg. Just a lot more specificity related to codes. Kidney disease also similarly had a very small bump, not terribly significant. Another one, just to note, that was about as significant as atrial fibrillation was peripheral neuropathy. The same thing, this now created just many more opportunities to code for different parts of the body that could have peripheral neuropathy, but it's really stayed stable. So there was that initial bump, and then the prevalence has really stayed stable. So as healthcare systems are changing, these are dynamic systems, of course, and we're trying to do research within these systems. We need to understand how the data we're working with are changing. But the big takeaway that we have from here is that things have stabilized. And then perhaps the most important issue is, is the VA-Fi still predicting the outcomes that we're interested in? And so this is looking at hazard ratios for mortality. And even right at that inflection point between 2015 and 2016, there was no change in the hazard ratios for mortality across any of the frailty groups here. What did change, and this was before the ICD-9 to ICD-10 change had happened, was that those in the severely frail category have an increasing hazard of mortality relative to those who are non-frail, and that's been rising over time. And whether that has to do with advanced care planning and decisions made to not pursue intensive care decisions at the end of life, I don't know the answers to that, but this is something that at least we know is going on. But again, thinking about our ICD-9 to ICD-10 transition, there really has been just tremendous stability in the VA-Fi's ability to predict mortality. When I mentioned earlier that we were looking at developing a frailty index that could be repeated, we were thinking about it specifically for trajectories of frailty, and particularly for change in reversibility. And if we think about frailty not just as a predictor, but also as an outcome, something that we want to intervene on, we want to make sure that this is something that's going to change. The way we've set up the VA Frailty Index, we have a 3-year look back, but only a 3-year look back. So claims can't be carried forward forever. If somebody had cancer in 2002, 2003, and then they were treated and cured in 2004, and then it's no longer an active disease, then by 2007, 2008, that code is going to drop off. They're no longer going to have cancer. And so what we did here was we looked at trajectories of frailty in a cohort of about 200,000 veterans. We used a birth cohort who were all born from 1927 to 1934. And we looked at their trajectories of frailty in the 5 years before death. I will admit that this work was done pre-COVID and in a different era relative to the computational power that we have now. And at the time, we were limited to this cohort of about 200,000 veterans because of our computational power. And so what we did was we started to look at, well, amongst people who are in the non-frail, so combining both pre-frail and non-frail groups, what are the different types of trajectories here? So we've got 2 clear lines of stability, the blue and the orange, and we've got 2 lines that are increasing in their frailty levels. Then as we look at the mild frail, same type of pattern, relatively stable in the black, increasing in the green. Then we identified amongst these moderate frail a clearly reversing group. This represents about 7 to 9% of the cohort, and then another stable group, actually really both very stable groups. And what was very interesting to us is, I'm not showing it here, but there was a small group of individuals who actually had an even higher frailty index above 0.7, which is often considered to be sort of the upper limit of what the human body can handle as far as the number of deficits that you can have and still be alive. We don't exactly know who those people are. We believe they may represent some of our spinal cord injury veterans, and there's more work ongoing there. But the real takeaway from this work was that we saw true reversibility amongst individuals who were in this mildly frail zone, maybe early moderately frail zone. We saw true recovery that is clinically meaningful. The other thing we looked at in this group is, were there differing causes of death based on these frailty trajectories? And one thing that really struck us very early was the death from cancer. So in people who were non-frail and pre-frail at the beginning of this 5 years, now granted, again, it's a look back, this is a decedent cohort, the number 1 cause of death in these people was cancer. And when we look back, many of these cancers are actually preventable, which ties back into what I was saying earlier. Are we perhaps not providing preventive care to people who may benefit from it because their age may be above 80 and yet their frailty will make them biologically younger? So there's a lot more work that we need to dig into here to understand how do we individualize and personalize care. The Frailty Index is really giving us a tool with which we can do that. Another question, thinking about data challenges, is at what age should we start addressing or assessing frailty? In many epidemiologic studies in the United States, people begin with the age of 65. And the reason for that is purely because of how data are available to us. So from 65 and older, most individuals in the United States have coverage from Medicare, and that just makes things easier because we've got access to data. In VA, if we focus in on patients who are coming in for regular care, we've got anybody over the age of 18 who's served. And so what we did here, this is a cohort of veterans who were undergoing heart surgery. So these are all people undergoing CABG, 13,000 US veterans at major cardiac centers across the country. And we looked at their frailty and outcomes in the 5 years after their surgery. And so not surprisingly, up here on the left top panel, you can see that those who are frail have worse outcomes compared to those who are non-frail. In those who are over 80, frailty index actually is not helping a whole lot. And that's because surgeons are really quite good at selecting people for surgery in the older years. People who are functionally impaired, who are living in nursing homes, they're not going to be offered open heart surgery. On the other hand, we were very surprised to see that in the group age 40 to 60, there was a doubling in the risk of 5-year or in the cumulative mortality amongst those who were frail prior to surgery. And so what this really told us is that frailty is relevant even in younger veterans. Now, granted, this is in people undergoing cardiac surgery, but this is the first data that we have just recently published that really highlights the value of frailty in younger individuals. It also showed us that for people who are getting their regular care, we can do a nice job of identifying their frailty status. So the VA-FI has become a very powerful tool for epidemiologic research across the VA. It always amazes me. We went from a small group of geriatricians sitting in a room in 2016 saying, let's build this frailty index. And now this has just exploded around the country. It's very exciting to see just how much work we've been able to do. I want to highlight work by one of my mentees, Will Schroner, who looked at the association between VA frailty levels and cardiovascular mortality over time. And this was very nice. There is a very clear risk or link between higher levels of frailty are associated with a higher risk of dying from a cardiovascular event, and that's here in the orange, compared to people who are non-frail in the blue. And yet, over time, we might be doing something to prevent cardiovascular disease events in people, even those who are frail. And so just an example of some of the research that we're doing related to frailty and cardiovascular disease. This is not my group at all, but just an exciting example of when you build a tool and you make it available to others, people will run with it and do all sorts of interesting things. This is a group at UCSF that asked the question of what is the association between the VA Frailty Index and risk of suicide attempts. And so those who are frail are more likely to attempt suicide than those who are non-frail, although lethality is higher amongst those who are non-frail. So certainly suicide is a very high priority area for VA and prevention. And so this represents another way of thinking about identifying high-risk individuals. So how does the VA-FI compare to other frailty tools? And there are lots of different tools that are out there, but we'll specifically look at some other frailty indices and some clinical tools here. And I bring Ken Rockwood and his group's clinical frailty scale here down at the bottom because it is a tool that we use clinically all the time. And I'll show you some data for that. So first, one of the places we started as I'm an epidemiologist was going into the Million Veteran Program, which is a prospective cohort study of veteran volunteers. There have been 1 million veterans now recruited since 2011. We've got multiple sources of data. We have their survey information that they provide. We can link to the electronic health record, to Medicare, genotyping, and others. For today, I want to focus in on what we've been able to do for frailty. We've developed an MVP frailty index, which is based on questionnaire data. A large portion of this relates to self-reported function, self-reported morbidity, mental health, and then memory issues. We've got the VA-FI, and then we were able to use the questionnaire data to use a variation on the Fried or the physical phenotype called the study of osteoporotic fracture. And this focuses on 3 things: unintentional weight loss, low energy, and then requiring assistance for transfers. And what we did was we looked within a cohort of almost 200,000 veterans who had complete questionnaire information, and we calculated their MVP frailty index, VA-Frailty from the EHR data, and their modified FREED. And what we found was actually very interesting, and this data is under review and we hope will be published soon. Amongst people who are over the age of 65, there's this nice increasing prevalence of frailty with age. What we weren't expecting, and I can't fully explain it yet, is that in people who are younger, using the self-reported questionnaires especially, there is a higher prevalence of frailty than we were expecting to see. That actually mirrors what we might see in 70 and 80-year-olds. We dug in a little bit, and we think some of this might be driven by self-reported mental health, as well as function. It could also be that we just don't know a lot about what frailty looks like in younger individuals, and we're going to learn through this work and these tools that we've developed. And perhaps some of what we see in the older cohorts really has to do with survival bias, and that people who are very frail in their 40s and 50s don't live to be 70, 80 years old. However, regardless of which definition we use, we did see that each frailty index was associated with outcomes. And so what I'm showing here are increased risk of cardiovascular events, heart failure, myocardial infarction, and stroke. And shown in red, we should probably flip these colors, but in red are the non-frail or the robust, in green are the pre-frail, and in blue are the frail. And no matter which tool you use, whether it's the MVP-FI, the VA-FI, or the modified FREED, with increasing frailty, there's an increased risk of having a cardiovascular event. And so this is very reassuring as we get back to some of that debate of which tool is the best one to use. I like to always say, use the tool that's available to you. That's the best tool. Now, of course, though, for a healthcare system, we want to try to be as parsimonious as possible, and there are other claims-based frailty indices out there. So working together with the Geriatrics and Extended Care Data Analysis Center, we asked the question of how do 5 different claims-based frailty indices compare in VA data? And we used the GENIFI, which is a proprietary frailty index developed by the Robert Wood Johnson Foundation. It's proprietary in that we don't exactly know what goes into it, which makes it a bit of a challenge. From a purist who follows the Rockwood approach, it includes infectious disease components in it, which I'm not entirely convinced are part of a frailty index. I think they may be better as an outcome, but that is the only difference, really, as far as we can tell, between the GENIFI and the VA-FI. We also looked at the Figueroa, which is another Medicare-based frailty definition that really focuses in on just a few codes related to function, cognition, and nutrition. And then we use 2 other claims-based frailty indices that also include utilization and demographics. Jody Siegel's work, which is a derivation of the FREED, so it's intended to map to the physical phenotype, and Day Kim's Medicare FI. And so we took a cohort of 2.6 million veterans, 65 and older, who were seen in 2014, similar to the prior demographics that I showed you, but 80% white, 90% Black, and using all of those 5 different tools, up to about a quarter of the population were frail. Interestingly, only 3% of this entire cohort were identified as frail by all. So that's right here in the middle. There's 68,000 individuals who are identified as frail by all. What really stuck out to us here is that the Medicare and the Figueroa are pretty much captured by the VA-FI. But down here in the red, about 100,000 people are being identified as frail by the GENIFI, and another 160,000 people are being identified as frail by the Siegel, or that FREED type of FI. And so we said, what is going on here? We're identifying different people. Who could they be? And what actually became very clear very quickly is what's going on with the Siegel is it's identifying older individuals, because part of the variables included in the model are age and sex. And so here, amongst all veterans over the age of 85 who were in our cohort, of the 370,000 or so, 82% were identified as frail. And the majority of that was actually by the Siegel. A third of that was by the Siegel. When we look at women, this is where it becomes even clearer. almost half are being identified as frail just by the Siegel. And so this is certainly has given us a lot to think about as we think about which of these frailty indices are we going to implement and perhaps which ones may not necessarily work. But back to our prior point, from a predictive validity perspective, all of the CFIs identified increased risk of long-term institutionalization and mortality, and shown up here in the upper panels are the unadjusted models for long-term institutionalization and death. And when we adjust for age and sex and utilization, these all completely go away. If we were to just look at the 3 frailty indices that don't include sex and utilization, they perform quite similarly for long-term institutionalization. The VA-Fi does a little bit better. If we look at mortality, the VA-Fi also does a little bit better, but when you adjust for everything, they're essentially interchangeable. Another interesting question that was asked by our group, and this was presented at Academy Health last year, is there value in perhaps adding up frailty scores if you're frail by 1 frailty index compared to if you're frail by 5? There may be some value for that. We're still exploring this to understand what this might mean, but just some interesting things that we can do with this data. And as we think about, the VA-Fi is not the only tool that's out there. There are others. Is there a way that we can use these tools together? Now, coming into the clinic, one of the questions that has arisen is, what about construct validity? So we know the VA-Fi has content validity. It was developed by geriatricians based on the CGA. It's got predictive validity for all sorts of outcomes. What about its ability to really capture what we think frailty is? Are we just capturing morbidity, or are we doing more? So we did a pilot study in 3 VA Boston clinics, primary care geriatrics, geriatric cardiology consults, and geriatric oncology consults, where we followed 132 patients, mean age of about 81, and we did functional assessments. We did a full CGA frailty index using Dave Kim's tool. We did the clinical frailty scale, and then we said, how does the VA-Fi correlate with all of these measures? And it turns out quite well. So if we look at the VA-Fi and the CGA-Fi, we saw that as the VA-Fi goes up, the CGA-Fi is going up as well, which is what we were expecting. We saw that there are individuals with a higher VA-Fi were more likely to be in the highest category of a clinical frailty scale, were more likely to have ADL dependency, and more likely to walk slowly. When we ran the numbers here, the correlation is moderate, which is not bad at all. And you can certainly see that the overall direction of this line is exactly where we want it to be. And perhaps most importantly is that for every 0.1 unit increase in the VA-Fi, there were associated increases in the CGA-Fi, in IDL and ADL dependency, in slower gait speed, and so on. And this was true even after adjusting for age, sex, race, Charleston Comorbidity Index, and so on. And so we believe from this work that we've shown construct validity of the VA-Fi. And so having done all of that work, showing that we've got a VA-Fi that works, is predictive, is able to actually correlate with these clinical outcomes, then we come to our clinics finally. And so as we all know, there are many tools to identify frailty. We've just been talking about one, and that's the passive tools, or these EHR claims-based tools. There are initiatives that are already ongoing across the VA to geriatricize the VA, if you will. The Age-Friendly Health Systems is probably the largest of these initiatives that's ongoing. And what's really interesting about this whole framework, it's a brilliant one. It really gets at many of the things that our patients worry about, maintaining their mobility, making sure that their cognition is staying as well as it can, monitoring their medications and focusing on what matters most. What's missing here really is that multi-complexity of geriatrics, where frailty, I think, can play a major role. And so as we're thinking about rolling out this whole age-friendly system, we're also thinking about how do we integrate the VA-Fi into that. And so there are a number of places where we're doing this, and this is just giving you a bit of a snapshot of what we're doing, and I hope I can come back in a few years and update you with exactly what we've done. So in primary care, what we're doing is thinking about whether the VA-Fi can replace some of the time-intensive screening questionnaires. And there's one implementation study that has been funded to Drs. Brown and Nicosia, that is going to examine the association between the VA-FI and various functional status measures that are currently collected in primary care. And we hope, if this works, that we might be able to replace some of that in time-intensive work. I think the most exciting thing that's happening right now, and this is coming to your doorstep soon for anybody who is within the VA and has dashboards that they manage. Every ambulatory clinic has a dashboard that will look something like this. Now in the VA, of course, to protect privacy, we often have these easy mouse names that we have here, and so I've just kept those. But you can see that there's a lot of information that shows up on these dashboards. We have age, we have gender, we have the CAN score, which is the Care Assessment Needs Score, for identifying veterans at high risk of a short-term readmission or mortality. We've got the Gen Frailty Index that's already here, and some other risk adjustment scores and information that's available. What we hope will be coming soon is the VA-Frailty Index, to add that in here. And the plan is for monthly data pushes that will make this available for population management, and this will be coming out of operations. With macros that will be published. This is all being spearheaded by the colleagues at the Geriatrics and Extended Care Data and Analysis Center. And we're going to be making all of that code readily available. But in addition, the data will be there for pulls into the dashboards. In the specialty clinics, my colleagues, Dr. Clark Dumontier and Dr. Nate Fillmore, are working on translating the VA-Frailty Index into a point of care application. And this is just, with their permission, I'm sharing some of their preliminary work that they're working on for their app. So this would show a different type of dashboard. This is showing patients in the hematology oncology clinic with, of course, names blocked out, and it shows the frailty category here. Now, on the one hand, it's very nice to get that frailty category, but then, of course, the question is, what are we going to do with it? And so if you go to the next screen, you would get this, a frailty score of 0.35 for an individual. And then what it's going to do is break down the various different health deficits that are contributing to frailty. And what this allows is clinicians to develop a differential diagnosis and a care plan related to that. So if we're planning to take somebody to surgery or take somebody for chemotherapy, and we identify, wait, this is somebody who would really benefit from concurrent physical therapy and treatment of their anemia, because we've identified those components on their frailty index, then perhaps we can optimize their care. I don't have any data yet on outcomes, but our hope is that if we can bring the frailty score in this type of tangible way to the clinics, that we can really make a difference for clinical care. And then, of course, that brings us to that last pillar, which is really, what are we going to do with these FI scores? We need education. And so I thank Dr. Andy Clegg, who had shared this slide actually in this same forum about 2 years ago, and we just recently published together a New Horizons in Frailty work. Where are we going? And this is one of the things that we wrote about, which is what do we do with these scores? And so this is just one framework that could potentially be used to say, perhaps for mildly frail individuals, we need to really focus in on physical activity, post-acute transitions of care, and similar. Whereas for the severely frail, perhaps that's where we prioritize serious illness conversations and advanced care planning. So there's a lot of work to do. There are opportunities here. We have the largest integrated healthcare system in the US. We can do a lot. There are already plans underway to geriatricize our health system, and bringing the VA-FI into that can really help with population management, might help replace some of the time-consuming screening with automation. But as I've acknowledged, there are challenges. We can't capture non-VA data in real time in an easy way. How we're going to get the VA-FI from those dashboards exactly to the point of care is a work in progress. That's not going to happen overnight. It will take time. And then how do we interpret, educate, and then finally disseminate all of this out there? So for everybody watching today, we've made the VA-FI readily available, both internally within the VA and externally on a GitHub website here. It's also accessible through our publications. We include that. And our operations teams are working on macros to make the VA-FI available for operations and clinical quality improvement work as well. And this is not limited to the VA-FI. It's also going to include other frailty tools, other relevant morbidity scores like the Charleston, to make all of this work more accessible and easier for anybody to do. I'm going to end on this note, which is frailism the new ageism? Let's just be mindful with all the work that we're doing, that we're not just replacing one ism with another ism, and rather that we use the opportunity to improve care for everybody, for every older adult. And so, of course, I could not have done this work alone. It takes a team. This is just some of our incredible colleagues here in Boston and elsewhere. And with that, I will say thank you, and I'd love to open it up to questions.
Thank you, Ariela, for a great presentation. And yes, we have a few questions, and I think let me start with the first one. And I guess you kind of touch upon this, the issue of education. And now you are getting ready to implement in the VA, but the question is coming up also outside the VA. So what kind of training and education would be needed for healthcare providers in the VA or outside the VA system to effectively use the VA-Frailty Index, and how can these needs be met?
That's a great question. Well, I think these types of forum are fantastic to start to get the word out. In our Harvard Geriatric Review course, just so you have to give a plug to that one, we do talk about frailty. I know that there is a frailty course, I believe one down in Miami, and there are others that are out there. But actually what my colleagues have been doing here in Boston is thinking about, from medical school all the way up, nursing programs, physical therapy programs. Frailty in many ways is a vital sign, and it's just as important as many of the other things that we do in medicine. So writing, speaking courses, all of that, and perhaps as we really bring this to clinical care, is having some interpretation alongside it. And that's part of the pilot study that's ongoing with this app now in oncology, is understanding exactly that. How do we ensure that we're educating while we're giving information?
Great. So another question, and of course, this one is related to the impact of COVID. Do you think that the impact of COVID will affect the demographics of frailty? That's an excellent question. I think more younger veterans becoming frail, 55 to 64, more sex differences in frailty. I don't know. There have been some publications on that, but.
There have been some publications. I don't think we know yet. The dust hasn't quite settled for us to say with any certainty. We do know, and I'll give a shout out to my colleague, Dr. Ben Seligman, and Dr. Katie Weisham, who are doing exactly some of this work to understand how is frailty, how did COVID impact frailty? Is it worsening frailty in individuals? I think I can share just a kind of brief, quick answer. Yes, I think we all know that clinically, and then we're going to have the data to support that very soon.
Exactly. What's interesting is the overlap or long COVID symptoms with frailty, right? Even in young, older people, right?
Yeah, absolutely.
So another question, hello Ariela, is from Enrique. I really enjoy your presentation. I noticed that inflammation is a common factor in several domains that are considered when creating a frailty index. I was wondering if you have any experience in including inflammatory or other, or other immune markers in the frailty index, especially when comparing infectious disease outcomes?
That's a great question. We intentionally, and I didn't mention this, but we intentionally did not include labs in our frailty index. We wanted it to be as versatile as possible and not to lead to a lot of missingness, and labs can be missing for all sorts of reasons. I'm not entirely convinced that adding more things to the frailty index will necessarily change its predictive ability. And yet, within individual populations, we do know that inflammation makes a difference. It's a very active area of study, and I think there's more to be done. And it's a very astute comment to say that inflammation is probably driving a lot of what's going on in frailty.
In general, and we know that in
and in aging.
Every condition, right? Cardiovascular disease, especially. I'm going to try to translate one of the questions, or maybe one before. Is there a plan to evaluate the cost effectiveness of the VA-Frailty Index?
As we're moving into the clinical space, yes, absolutely. We have not quite done that yet because we've still very much been on the research side. And in some ways, what we're doing represents a very rapid succession of developing a tool, showing that it's working, updating it for the current clinical needs, and then now bringing it out there. But yes, I agree. We'll need to look at cost effectiveness for sure.
another one, and I know we're running out of time, but it relates to, it's in Spanish, but I'll translating. It relates to the issue, the dental issues that are, of course, and I think the question implies if, I guess, the evaluation of dental complaints and issues and how that influences the trajectory of frailty. And I don't think we have any data with the VA-Frailty Index that I'm aware of, right?
Not with the VA-Frailty Index. You know, some of the frailty work I've been involved in, we've been able to include dental health as a variable or as a deficit. That was not a readily available deficit, so we didn't include it for the VAFI. And I'm not aware of any studies right now looking at that, but it's a very good idea.
Yeah. Right. The problem in the VA is that the eligibility for dental service is very restricted, so it may be a very biased group, right?
Exactly, but there are changes in terms of Medicare and dental benefits that are just coming into play, and so what that might mean in the future, we'll have to keep an eye.
Great. Thank you again, Ariela, for a great presentation, very illuminating data. We hope to have you back again. I'm sure we're presenting new data that you'll be inundated with in the next few years. We're especially excited with the clinical implementations. And thank you again. And thank you, everybody, for participating in our webinar. And I want to remind you to join us on Wednesday, April 10th for our next webinar. It's going to be about recent developments in frailty epidemiology, and a well-known investigator in the field of frailty from Netherlands, Dr. Emil Hugendix, from the BU University Medical Center in Amsterdam, will be presenting to our audience. And thank you again for joining us. Take care.